Assalamualaikum and hi. So today our group, me, Faisal, Alif and Alia will be presenting about the case study which is for retinal detachment, rheumatogenius. So what is rheumatogenius retinal detachment? Rheumatogenius retinal detachment is one of the most common types of retinal detachment. It happens when the patient has a small tear or break in the retina. And if there is a tear or break in your retina, the gel-like fluid in the central part of your eye, known as the vitreous, can penetrate through the opening. Consequently, the vitreous exerts pressure on your retina and displacing it from the back of your eye and resulting in detachment. So for the case study, there is a 61-year-old male university professor of Caucasian descent seeks medical attention due to a sudden and progressive loss of vision in his left eye, which began yesterday morning. The patient describes the experience as if a curtain were extending over his affected eye and now impacting his central vision. Additionally, he recalls observing flashing lights and developing flutters in the same eye 7 days ago. Notably, there is an absence of pain, double vision, halos, metamorphopsia, or other associated symptoms. And the patient mentions having undergone cataract surgery on his left eye 3 weeks ago. So looking at his past medical history, he had hypertension, which is well controlled on medication osteoarthritis. And his past ocular history, he had cataract surgery for left eye 3 weeks ago, and there is no other history of surgery, trauma, amblyopia, or strabismus. And there is no ocular medications, and he also had surgical history with right knee replacement in 2005 and past family ocular history. Her mother had age-related macular degeneration with no history of retinal detachment, glaucoma, blindness. And for social history, he is non-smoker. He also take medications such as hydrochlorothiazide, lisinopril, and he has no allergies. And for the result of his pupil, it is equal, round, and reactive to light and no APD. For intraocular pressure, for his right eye is 16 and for his left eye is 11. For his visual acuity, his right eye got 20/25 and his left eye counting fingers at 3 feet. For the result of confrontational visual field, it is full to finger counting arc and central inferior and nasal field deficits left eye. For extraocular movement, it is full and no nystagmus. And for external, it is normal for both eyes. And then for the result of slit lamp examination, his cornea, conjunctiva, sclera, lids and lashes, and iris is clear and normal for both eyes. But for his lens, there is 1+ nuclear sclerotic cataract for both eyes. And for the anterior chamber, it is deep and quiet for both eyes. And anterior vitreous, it is normal for right eye and pigmented cells for left eye. And then the result of dilated fundus examination for his right eye, there is a clear view, flat macula with normal foveal light reflex and normal peripheral retina and blood vessels. And then for his left eye, there is a clear view and there is a large area of subretinal fluid extending from 10 o'clock to 4 o'clock fluid under the macula, which is made of retinal detachment, and a tear is identified at 2 o'clock, and small amount of vitreous hemorrhage noted at the site of the tear. Next, I pass to Alip.
Hi, Assalamualaikum. So, for the diagnosis and justification, the peripheral retinal tear causes rhegmatogenous retinal detachment. This patient has a retinal detachment caused by a retinal tear. Other illnesses to consider are choroidal detachment, choroidal effusion, choroidal hemorrhage, and also subretinal tumor. This patient has a rhegmatogenous retinal detachment caused by a peripheral retina break, which is most likely the result of vitreous tension on the periphery, and the recent cataract surgery might have caused this disease. Cataract surgery increases the amount of space available in the vitreous chamber, where the new lens is thinner than the excised cataract, and it will allow the vitreous jelly to move. Peripheral lattice, severely myopic eye, posterior vitreous separation, trauma, aphakia, and also sickle cell disease are all possible causes of rhegmatogenous retinal detachment. Next. Yes.
Lastly, for management and treatment, the most common treatment for rhegmatogenesis detachment is surgery. So, rhegmatogenesis retinal detachment is an emergency cases. So, patient needs to take um, treatment as soon as possible. And the procedure includes scleral buckle, pneumatic retinopathy, and vitrectomy. For scleral buckle, after precise localization of all retinal breaks, tears, and marking of the sclera, the holes are treated with cryopexy for scar induction. The traction exerted on the holes by the vitreous body is then reduced by a foam sponge centered to the sclera. While for vitrectomy procedure, it begins with the removal of the vitreous humor causing the retinal detachment, followed by displacement of the subretinal fluid by means of a heavy tamponade and scarring of the retina by laser coagulation or cryocoagulation. The vitreous is then replaced by a tamponade. So the purpose of this surgery is to relieve vitreous tension and bringing the retina closer to the underlying choroid. Overall, the current surgical techniques have an 80 to 90% of rate. So that's all. Thank you.